Hey students, this is going to be your review for high-risk maternal. So with that said, let's get started. Complications of maternal health include spontaneous abortion. Clinical manifestations are spotting and cramping. Spotting is common during pregnancy, but it's when you have the spotting and the cramping that is more indicative of miscarriage. Treatment would be to monitor the HCG levels, bed rest, and if miscarriage is imminent, D&C will be performed. Ectopic pregnancy, it's when gestation occurs inside the fallopian tube. You will have the usual signs of pregnancy, but you'll also have unusual bleeding or spotting and pain. It's important to get a thorough health history from your OB patients, and just know that if your patient has already had an ectopic pregnancy, they're at higher risk for developing another one. Methotrexate is given to the mom to stop the growth of the embryo, and then laparoscopic surgery is performed to remove the embryo. Placenta previa, it's the most common cause of bleeding in the later months of pregnancy, usually seen after the 7th month. Ultrasound confirms the location of the placenta, which has implanted incorrectly. Clinical manifestations, painless bleeding in the second half of pregnancy. It's the #1 sign. Treatment, hospitalization, bed rest. Rule out other sources of bleeding like abruption, which is more emergent. You want to monitor blood count and monitor the baby very closely. Also monitor contractions. C-sections are the method of delivery for patients with placenta previa. If the patient is experiencing contractions, call the physician because the birth will not be normal. Fetal complications include preterm delivery, intrauterine growth retardation, fetal distress and anemia. Maternal complications are hemorrhage and potential DIC. And also know that your pregnant patients are at increased risk for developing DIC. In abrupto placenta, the placenta implants correctly, just maybe partial or complete. The placenta separates prematurely, which then bleeds. It's usually seen in the last half of pregnancy. Ultrasound will be needed to confirm the diagnosis. Causes could be trauma, could be illicit drug use, smoking, previous C-section. Manifestations include rigid board-like abdomen, may or may not have vaginal bleeding, abdominal pain, and then difficulty palpating fetus. Treatment, cesarean section. Remember in your OB patients, if they have unexplained vaginal bleeding, do not do a vaginal exam. Priority is, of course, monitor mom and baby and prevent fetal and maternal shock. Preeclampsia, increased blood pressure, proteinuria, edema after 20 weeks. If mom's baseline pressure isn't known, just start with 130/90 as a benchmark. Clinical manifestations include weight gain, swelling of the hands and face, headache, blurred vision, any sort of vision changes, hyperreflexia, that will probably be on your exam. If not this exam, then definitely boards. Clonus, which is a huge risk for seizures. Treatment for mild preeclampsia. Preeclampsia is systolic pressure between 140 and 160 and diastolic pressure between 90 and 110. Bed rest, increase the protein in the diet. Severe preeclampsia is categorized by blood pressure with a systolic of greater than 160, diastolic greater than 110. You want to give sedation to delay seizures. Mag sulfate is used in severe preeclampsia. It's an anticonvulsant and a sedative. Delivering the baby is the only true fix for severe preeclampsia. Nursing care, make sure the patient's in a single room, which of course they will be. Quiet environment, do not overstimulate mom and baby. Additional treatment could be steroid therapy. And then eclampsia is when the patient seizes. So if they have preeclampsia and they seize, now we've moved into eclampsia. Of course, monitor mom and baby, watch for heart failure symptoms, stroke, heart attack, renal failure, DIC, HELP syndrome, neurological damage, and multi-system organ failure.